We've got, I think, a good case here that follows those talks. If you want to pull up the clinical background here. So this gentleman just showed up to our clinic a few weeks ago, actually, from the other side of the country.
I don't think you could find anyone to do this in New York, right?
That's what he said.
Yeah.
So relatively healthy gentleman, born bicuspid aortic stenosis, or bicuspid aortic valve, developed aortic stenosis back in 2015, had a ascending aortic aneurysm, I think it was 5.4 at the time, ultimately underwent AVR with a 25 Magna and ascending repair. Otherwise,
so for a second, can I talk about that? So the ascending repair, he actually had a sinus of Valsalva graft, a Terumo graft, and sewed the valve into the graft first, and then implanted it as a composite, and then reimplanted the coronary. So there are some sinuses here, and the valve sewn into the graft. So it's a 25 valve inside of a 28 graft.
So otherwise, just AFib, sick sinus syndrome with a pacemaker, and then the usual hypertension, hyperlipidemia. Next slide. So you get a sense of how big these sinuses are and the graft in comparison with the valve. Next slide.
Yeah.
You can skip this. He's got a pacemaker. This is his underlying QRS. So good coronaries, actually really good coronaries. No disease here. Next slide. All right, same thing. So great coronary, adequate sinuses. You can measure in football fields the VTC. Next slide. VTC here, yeah. 11.5 on the right and 9.7 on the left. Next slide. All right, so this is where I think some of the discussion can be had. So if we decide to fracture, it would likely be a 26S3 or 29 evolute without fracture, potential 23 versus 26. Next slide, I think. And then see the access point here. So we struggled a little bit with this. Really no calcium or minimal calcium, but quite tortuous through multiple wires to get up. But we ultimately ended up putting in a dry to help with our tortuosity. So, all right, done with the slides there. So we're going to get you guys up to speed. So we got a dry seal in. We've already crossed, which take a little bit of time here. We have Safari in, and we have our device up in the aorta. I don't know if anyone wants to make any comments on the panel about valve selection, fracture here in this gentleman with a 25.
Well, Bob, as a fellow surgeon, so this is a self-constructed bioconduit, correct?
Correct.
So the problem with fracturing that is you don't have native tissue, you have Dacron around that valve, and Dacron has no distensibility. And there aren't any real data about fracturing valves that are bioconduits. So I'd be hesitant to fracture this because you don't have native tissue that can expand. And I would comment that you have this thing lined up right now for perfect commissural alignment.
So let me ask you this. Does the fact that you're not going to frac this in any way affect your valve choice? Michael?
Well, yeah, I mean, it typically, unless your valve has a 23 inner diameter or bigger, Danny DeVere showed us there's real problems. That's a 25 valve is a 23. You could do either one you want, but I wouldn't frac this valve because of the Dacron. And yeah, typically in valve, I tend to use self-expanding valves, particularly if you have a football field of space like Bob has shown us. That's the simplest thing to do is put this in. You'll get the best hemodynamics out of this. You could use other. I mean, again, the guy's young. He's 73. That means he and I could have gone to high school together, which we're a couple of young guys. And so I assume, like me, he's active, so you want to give him the best hemodynamics you can.
Jonathan, what's your approach?
In general, I think self-expanding is the best choice for valve and valve, but this is relatively large.
Relatively large, that's right.
They're 84.
Yeah.
I think you can get a good result with either one.
Right. Srini,
before he crosses, I would say, often have a snare ready just in case, because I have
a snare ready.
Yes, because I found this being the most difficult part of the case.
Particularly with a graft.
Yeah.
So he's talking about snaring the valve, having a snare ready to go around the valve, around the shaft of the device, and boom, he didn't need it.
Nice.
Yeah, that was nice. And what you do is the second operator.
We've got a
second operator would
have a couple of snares on the back table.
Yeah, okay,
so I got a question about the snare because we talked about that. If we, if we couldn't have done what we just did, we would have had to pull the wire out and recross. Would anyone have crossed through a snare just prophylactically?
You know,
Sounds like a lot to do.
some people have the snare, when they say the snare ready, have it on. It doesn't hurt to have it on, ready to go. Other people just wait until they can't do it, because most of the time when you think you can't cross, you can, right, Herms?
Well, I will comment that you know, you're in an overlap position there, kind of, but your valve is your commissures aren't
Yeah,
lined
it's not-
up. Your hat marker should be right in the front in this position. Now, it may not make any difference for this guy. He's got real big sinuses anyway, but
It's also not fun, but at least with the Evolute, if you had to and you didn't use a snare up front, you could come out of the body, put the snare on, and then go back in.
yeah, the only time that's painful if you're doing it in
Go
line,
in a
then you
little
got to
bit.
hold your finger
yeah.
on the hole.
And
You're going to be torquing there.
yeah, we're not doing much.
What are you guys pacing at?
We're not pacing. This is just the wire pushing
Oh,
up
I
against
see.
We're
it.
trying
Okay.
to fix
What we're
Dr.
trying to do is
Reardon's
see if
problem.
we can get this commissure line, the hat on the facing us here.
Well, the problem, Bob, is you really can't do it in there. If you really want to do it, you have to pull
Yeah,
it back
once
in the
it's there.
descending order, rotate it in the
Yeah.
descending order, and come back. So go over to a 2030 LAO, get the hat marker on the outside with it in descending order, then come back around. But right now, you can't get around the arch. You'll waste your time.
Yeah.
Here, push wire. Coming
Okay,
back.
there. So this is our 30 LAO, 23 LAO
Close. Yeah, there it is.
right there.
Your hat marker's on the outside now. You're good because you're now in a coplanar.
Okay. Yeah. So let's go to the coplanar, just show them the coplanar. And who would deploy the valve coplanar? Who would deploy it in the cusp overlap?
Herms, what are you going to do?
I'm fine deploying it right here.
Yeah,
Yeah.
I think this is a nice view.
Yeah. Well, this is overlapping, and you have a pacemaker already, so you're not trying to
Yeah.
avoid a pacemaker. I just do whatever's easy, Bob. It's not going to make any difference.
Valve and valve, your pacemaker need is lower anyway.
Paul, you want to turn the pacer on?
140. Is that coming back?
Yeah, pull the wire back a little bit. There you go. 140. It's a little deep.
Yep. Back with it.
Yeah. There's a very tortuous aorta here. We soaked up a lot of the catheter in the iliacs and again in the descending thoracic. So just
Wire.
yeah.
That looks good. Somebody just needs to keep a little forward pressure on the wire for you, but that looks good.
Go to
Maybe
180.
pace faster. Yep.
I'd let it come in just a tad, Bob.
A little high.
Push forward.
I'm pushing.
Yeah, you're not going to like that. So the thing to look at here is look at by the non-side. See, it looks
Yeah,
like a
the non.
tulip.
Yeah.
Anytime an
pacer
evolute
down.
looks like a tulip,
come
it's
down.
too high. It's trying to push itself out.
Yep.
Go
Yep.
deeper. We can land deeper too.
All right. So we're going to recapture.
You don't want to go back on
Push the
pacing.
wire forward.
We're running
back
a
on
theme
pacing.
this week.
And that's what happens.
Okay, come up a little higher so we can recapture above the valve. There you go.
Just leave it for now. Just keep it slow right now. They're not doing anything. They're just recapturing.
You don't want to capture the leaflets. I heard Dr. Greenbaum was concerned about that yesterday or the day
All right.
before.
Well, I would say it looks like your folks are still pacing. It's not going to hurt at 140, but generally I let them rest between.
He's at 90 there.
Yeah, start there.
Let's start there.
Really? That's kind of deep.
It's deep, but
Yeah, it's a little deep. But as you come out, you can feed a little wire. It'll go back.
I mean, you want to start pacing at
So
a
let's
faster
go
rate.
on. Let's go on pacing. Push wire there. It just keeps.
Oh.
We're gonna need to go pacing a little faster here.
Yeah.
Push forward.
Be careful.
See if you can cross if I need to recapture.
Yep, you recapture.
Yeah, you're not come back across. You're already outside of the capsule.
Pacing off.
Pacing down.
Come up and then cross again. Pacer off.
I would avoid pulling on the valve and use your wire to push it back. If you pull on the valve, it's going to go back too far on you.
Yeah, that's a lot of wire push right
Yeah.
there. Hold that wire there. Maybe I have to leaflet a little bit.
Yeah. Well, you know, it's going to dive a little bit, Bob. So if you start at about 0, you'll end at 3 or 4.
There.
That's what I was worried about. Push forward now.
I got it here.
So we're going to start at 0, end up at 3 or 4, right?
And I think we pace
Yeah.
faster here.
That
Okay.
looks,
All right.
That looks good.
it looks good.
Going to call
All right, let's go ahead and pace at 160 to start. 160 to start. Dove. Push wire just a little.
Wire.
Pushing and no,
Yeah.
nothing's happening. There we go.
Yeah, you're good right there. Yeah, don't pull
Hold
on
wire
it.
there, Tracy. Hold the wire right there, Tracy.
Let me dive a little. That's good.
Looks good, Bob. That looks good.
There it is.
Nice.
Now center the valve.
Popped.
That popped. Yep. All right, pace her down to keep going. We capture it fast.
This one, I think God's telling you just start lower. You got a pacemaker already.
I think so too. I'm in agreement with that. Come back.
Don't pull back. I don't have wire.
There.
Especially if there's a chance you're considering fracturing the unit, you should always go a little lower anyway.
Yeah, and you got a pacemaker. I mean, this is not an issue.
Yeah, there's no
It
need.
doesn't matter where you land this. Yeah.
All right, pressure's 142 over 50 for those of you who can't see it.
Okay. So let's go back on pacing at 160.
Maybe even going 180 to start, just to burst pace it and
I
get
like
it in.
that idea.
Go ahead and up it up to 180. Push.
Right. Right neutral there. Lean forward. Still constrained at the.
Michael, does that look like the same thing you were talking about on the first deployment?
Yeah.
I go pacing off.
Pacer down.
probably. Yeah.
Yep, it's already popped up again.
Coming up.
You know, guys, I would really deploy this deeper.
Just go deep.
Just go
yeah.
deep right now. No, other way.
I would take some
Hang on,
pressure
come
off
back
that
a little
wire.
there.
It's just popping it out.
So I would suggest you get it down to 4, Bob. Let whoever's in position 1 just tell them to let go of it for a minute. Get all
Andrew.
the tension out. And if it doesn't move, then you're ready to deploy. But if it moves, you still have tension, and that's what's moving. So get it where you want it. Just let go of it at the groin completely once you're where you are.
And I think Mark Reisman makes a good point. I don't know how much forward pressure on that wire.
We had a bunch at one
just
point,
take it
and then
off
we
then.
took it off.
Now, yeah, just let go. Let go
All right,
of it.
so that's
Now,
kinda
take your-
neutral right there.
Take your left hand off of it too. There you go. now there's no tension in the system. We're watching you from here,
Slowly roll it now.
and I just deploy right there. God's.
And
You
I'd
guys,
pace,
I
let's
think
pace at
there's-
180 here.
I think there's
I think
little disadvantage to a deeper than usual implant here.
Yeah.
You've got a pacemaker in place, and I think that might serve you.
It's way too deep, but pull back a little bit.
Yeah.
Pull back. Yeah, perfect. Keep
Turn the
going.
wire
Keep
a little,
going.
yeah.
Keep going. Pull back a little bit more.
A little
you guys.
more.
You guys will be fine. Keep pulling back. Keep coming. Keep coming.
You see, we pulled onto the lesser curve, and it hasn't moved a bit in the annulus there.
So recapture.
anchored.
There you go.
Yeah,
Keep it in.
yeah.
Stop there.
Push.
Now just give a slight forward force.
Yeah.
So you got all your
Yeah.
inertia
Yeah.
going back.
Lightly forward.
Perfect.
Yeah,
Perfect.
there.
Pull back a little bit.
That's looking good, guys.
Be pretty deep there.
Pretty
though. Be
deep. It's
careful, Bob.
diving.
Yeah, you
You
gotta come
dive
back
in
some.
though.
Push.
As
back.
we're looking.
Yeah, it's not going to kick
Pull
it
back
out
a little bit there. Right there.
That may be okay.
That's about perfect there.
That's still too deep. But let's
Now
let him
look at
breathe
that
a
on the
bit.
front.
Pacer
Further
come off.
straight down.
Pacer.
Pacer off.
Let him recover here a bit as a long pacing run.
But Bob Burke, what are you
Got a
seeing?
little flash of PVL there, not much.
Go to
Obviously
the
not fully
go to
expanded.
the planar view. Just flip the II.
Co-planar.
Co-planar, please.
Good. Quick cine, so it's brighter.
Yeah. So it's a little deep.
Probably could do a little bit better, frankly.
The pressure's recovered. We're at 136 over 64.
I kind of like where it is, Bob, because you may want to balloon to the inner diameter of the valve just to seal it, not to frack it. But you'll see what it looks like once you let it go.
Should come up a little bit on the left side also, 'cause it's just the way you are in the aorta.
So try for a little better or let it go and post-dilate.
I think God's told you you've done it enough times. I would pull my
I think
wire
so too.
back.
We've tried to land it higher, and it's popped out multiple times.
Pull your
So,
wire
I think
back.
if we're going to post-dilate.
so ask yourself the question, Bob Burke, is it in all interacting with the mitral valve, and how much PVL is there? Because you've got a pacemaker, so it takes that out of play. So Bob, in terms of those two questions, what are you seeing?
So we're not seeing any interaction with the mitral, so that part is fine. And we've got really almost nothing in the way of PVL. So
what's the
we got nothing
downside,
to
Michael?
complain about right now.
The only downside is you may not get the best hemodynamics because you're not quite as superannular.
Right.
But at this point, I'd say, you've already tried
We've
3
poked
times
the
before
skunk
this.
a few times, is that your point?
You're now starting to poke a skunk. We've talked about that. I'd let it go, Bob. I think you look good. Pull your wire back, let it go, take a look at it. If your hemos look good and you're happy, fine. If not, balloon it with something that matches the inner diameter of the valve just to seal it.
Mark, what are your thoughts?
Yeah, I agree. I think we're okay.
Yeah, I'm good with that.
So we're going to let it go here. We're going to rapid pace, have the wire neutral here,
Yeah,
and then
just
we'll
bring
have the
the wire
balloon
back
ready if we need to be. Yeah.
Just bring the wire back to the
So-
center that a little bit. Yeah.
Pull your wire back or my Medtronic friends will go crazy.
A little bit more.
All right, you happy with it there?
Yeah,
You have a
looks
little
perfect.
video delay. Okay.
It'll come up a little
Turn
bit.
the pacer on.
left side.
Let's
Rapid
go
pace.
up on pacing again. So we do 180. Let it come back. All right. All right. Wow,
That
all
opened
store
up.
tension.
Yeah.
Pacer off. Don't
And
forget
Store
that.
tension.
Pacer off.
That's a lot of store tension there.
Yeah.
You see, it's
Hey,
probably
Bob,
moved up a
hey,
millimeter or two
Bob,
with that.
or Andrew, would you guys cine that
Yeah.
so we can get a good, clear
Yeah, I'm
look
going
at that?
Hold right here.
Oh,
Yeah, that looks great.
Nice.
No, it looks really good, but it
good.
shows you how
Go
much
live.
tension was in that system when you let it go, and that's
Yeah.
why it kept popping out on you. We never really got the tension out of the system.
Yep.
Okay, go back and play that cine.
Centralizing the nose cone was critical. You see how it popped back.
Okay.
So let's go to the cusp overlap and cine that just so we can see depth in 2 planes while Dr. Burke is looking at our hemos.
I think it was the LEO crane.
All right, just cine it there.
Close, not quite it. But
That's a great.
So there it is in 2 views.
yeah.
It looks
You
very
might balloon that to
constrained,
modify.
yeah.
What, Mark, what?
So
I think
we're
it looks
pretty lined up. You have 2 dots under the post, so.
Yeah, I think it looks constrained. I mean, the hemos, we'll see what the hemos
need
look
to
like,
post
but I think you'd
Got a
benefit
mean
from-
gradient of 10 right now.
Yeah,
Let's take this out.
a mean of 10. Yeah, I would just take a 22 true and then post-still it.
Mark, this
Get a
looks
22
very
true
similar. Michael, this looks very similar to what we saw 2 days ago with the Lotus. A little constrained, but
Watch
the
your,
balloon was intended
balloon.
just to modify it, not to frack.
Yeah, if you want to fracture this, you need like a 26
Yeah,
true.
the-
and then
yeah.
I would take the
Take
waist
this.
and just use the 22 or
Very bleeding
23. 22 should be fine. Good.
It's being opened.
So Burke, you don't see any leak, right?
I'm not seeing any leak down here. I'm transgastric right now. Not seeing any PVL at all.
No, your echo looks perfect, Bob.
Transgastrics were good. That Dacron on the homemade graft is not very echo friendly. Let's put it that way. Almost everything was visualized from below or at the level. Not the most photogenic aorta in the world with that Dacron in there.
So not to pick on the first operation too much, but looking at the ascending aortic aneurysm bicuspid valve aorta of a 5.4, probably could have put a 27 valve even in this 28 graft, and maybe even gone a little bit bigger, but he sized it to the remaining ascending aorta, the arch, and that's where he picked his graft to put his valve that way. Not sure he was thinking about TAVR being the future for this person or not, but maybe.
Well, just hanging out right now, the gradient has dropped down to 9 to 10 so far, so still looking good.
That's on echo. That's great.
Yep.
Hopefully our balloon reaches.
We
got more wire regurg right now with whatever manipulation
we just went across with the balloon, so
gotcha.
Put that back there. All right. Pacing. Let's go on pacing at 180. Flat.
There you go.
Yeah.
Nice.
Yep, that looks better.
Much better.
And pacer off.
Oh, that's always so satisfying.
Take wire out with it.
We'll leave it. Probably not going to hit it again. Let's just get it back and see. Leave it there. All right, now what are you seeing on the gradient, Burke?
Mark, just for the record, I don't think I hurt my hemorrhoid
Lots
there.
of ectopy here, but okay.
That's
Yeah.
the wire.
And you know what, Bob?
He was having
with
a bunch
that, with that big syringe, you got about 2 atmospheres out of it.
Yeah, I think if you're concerned,
Our
we'd be
gradient
putting
dropped
inflators on
significantly,
this as well.
guys.
Yeah, look at that. That's low
Looks
node
about-
velocity.
So these are single digits,
Great.
getting a mean of 5, 5, and 6.2.
Great. Thanks, you guys. That was
So
great.
the nice thing about this machine is that it does all that automatically, so you can't see that I'm faking it. It's all done by AI.
There you go. Thanks, you guys. Great job. Excellent.